So we could have had by now in Ontario all the residents in long-term care, absolutely all of them vaccinated.
This is a long-standing problem of under-resourcing elder care.
We have not taken the protection of older Canadians seriously at all.
From the Zoomerplex in historic Liberty Village, the Zoomer with Libby Znaimer.
Welcome to the Zoomer. I'm Libby Znaimer. The rush of excitement over the arrival of COVID-19 vaccines in December quickly gave way to anger over limited supply and failure to cover our most vulnerable in long-term care. As of February, we've slipped to 33rd in the world ranking of per capita inoculations, with just 2.6% of Canadians having received their required doses. When will you get the vaccine? We'll discuss some of the deciding factors in a moment, but first, let's tee up the topic.
Now that the COVID vaccine is rolling out, vaccine hesitation has seen a steep decline. In a new survey,
Survey's done.
60% say they take the vaccine today, a 12% increase from just 1 month earlier. Older adults are most eager, but across the board, Canadians are willing and waiting. Over half say it's taking too long. Many fear it could take longer than 3 months. It's why some Canadian snowbirds are rushing to roll up their sleeves south of the border. Nearly 30,000 non-residents of Florida received the shot by mid-January. But for the rest of us here in Canada, it's very much a waiting game.
The Prime Minister keeps emphasizing the millions of doses set to arrive by the end of March. But why was Canada not able to acquire more vaccines early on? Paul Lucas.
Yes, well, that's a very interesting question. And let me start by just saying that, for Mr. Trudeau, this is a political issue now, a big political issue. He knows that this is the thing that stands in the way of his majority government. And frankly, they have made major blunders along the way here. And it goes back a long way. It would take me a long time to tell the whole story. But some of the issues are, first of all, the federal Liberal Party has no relationship or interest in the pharmaceutical vaccine sector. And that's existed since Pierre Trudeau was Prime Minister. So it's been a very unfavorable environment for pharmaceutical companies in Canada as a result. So when it came time to deal with the pandemic, they didn't know what to do. They didn't know who to call. They didn't know who to talk to. They should have been able to have a pipeline directly to the presidents of the global pharmaceutical companies, who were the only organizations that could possibly develop a vaccine for this pandemic. So, that's one issue. And the fact that Canada didn't actually fund any of the development of these vaccines is obviously putting us in a low priority position when it comes to accessing vaccines. So if you look at the US, the UK, Europe, they all participated in multi-million-dollar funding of these vaccines so that they could be developed quickly and with less risk. So naturally, they're going to be first in line. Everybody's heard of warp speed. That was a great move on the part of the US government. No matter what you think of the Trump administration, that was a great move. These vaccines were developed in record time. And the other issue is probably the fact that while Canada, the federal government, was trying to figure out what to do, they played around with the Chinese vaccine and thought that would be a solution. They funded Vito in Regina. They put money into Medicago. But the reality is that none of those organizations were ever going to be able to produce a vaccine for this pandemic. So there's multiple factors here, but the bottom line is it was bad planning and a lot of mistakes.
Why didn't we have doses at the end of the year when other countries did? I don't get that.
Why would you structure contracts to deliver 20 and 40 million doses from various manufacturers in April when you got approval in December? You would have structured those a lot differently, and you would have asked for more doses up front. I think the government did not plan for a scenario of getting approval in December. I believe they made their assumption that they were going to get approval in the first quarter, and therefore they structured their contracts around that. But in good scenario planning, they would have planned for a scenario of early approval, and they would have built their contracts around that. So they just didn't do the planning. They didn't think ahead.
Colin Furness, was it a big surprise that these vaccines were approved so soon?
Oh, absolutely. I mean, the fastest vaccine before this was mumps, I think, and that took about 4 years. I didn't hear a single expert all the way to November saying they expected the jab to start the very next month in December. That caught everyone off guard, and it's fantastic news. In a sense, everyone's being a little petulant. We're still ahead of schedule as far as that goes. I understand why everyone is obviously really, really upset about that. But as for poor planning, I think it's a little more complicated. On one hand, Canada signed more contracts for more doses than any other country in the world. So we actually had the foresight to say, there's a head shake, well, we did well, maybe I've got my facts slightly wrong. We had the foresight to do that. The contracts were secret. At the time, I thought, lack of transparency usually means there's bad news in there somewhere. Feels to me like no matter which vaccine got approved first, we'd at least have some. And it seems to me it's the execution and exactly the comments that have already been said about what were the terms, what was the structuring. And when things are secret and they aren't subject to public scrutiny, then, well, as I say, sometimes you unwrap the package and it turns out to be bad news.
Doris, do you think that it was just a fact that Canada just didn't order? I mean, I'm still trying to wrap my head around this. Did they not order these doses?
I think that Canada put the eggs in many baskets rather than on one. And I actually think that was the right thing to do. I think we will have plenty of vaccines. To me, the critical issue is the delivery. The delivery has been catastrophical. To put it in the hands of hospitals is the wrong thing, especially in Canada, where public health always takes the key role. I think the decimation of public health around the country has been a major issue in Ontario in particular. And primary care is the one that actually puts the shots in the arms, and we are still not using that. People are in the payroll and are not going to give the vaccines. So we could have had by now in Ontario all the residents in long-term care, absolutely all of them vaccinated, if the vaccines had gone only to the critical health professionals, that frontline persons, and to residents in nursing homes. That could have been accomplished already, and the numbers are there. But we didn't, because we gave to the accountants, we gave to the IT people, we gave to who knows who.
On that note, the general who is in charge here in Ontario, Rick Hillier, keeps saying that the reason that those vaccines were diverted was technical reasons. They couldn't bring it to nursing homes, although other countries and other provinces managed to do that. So do you accept that explanation, Colin Furness?
It's one way to spin it, but I think actually a better way to understand it is to say they solved the wrong problem. They've decided the problem was where to store the vaccine, and it turns out that hospitals are excellent places to store the vaccine. They've got the freezers. We needed to solve a different problem, which is how to deliver it to people who need it the most, which means storing it, yes, but also transporting it. We never tried to solve the transportation problem. We didn't put a freezer on a truck. That's what we needed to do. We didn't do it. And so once we stored it, we thought, great, problem solved. Oh, wait, now what? Well, it's in the hospital, so let's vaccinate people in the hospitals and people who can get to the hospitals.
And Dr. Bowman, the other question with all of this is was this just, again, other jurisdictions managed to get this done?
I think there's something more going on here, Libby. I think this entire pandemic, we have not taken the protection of older Canadians seriously at all. And, there's reasons, the ins and outs of why hospitals were doing what they did. It sent a horrendous message. And, we've had our face in this dilemma for so long now. We're not objective. In 2023, when the inquiries come out and the books are written, the fact that we were giving it to IT staff and medical staff that hadn't been in a hospital in 8 months, when driving distance away, you had active outbreaks and people dying. I mean, I think we have to take this moral failure very seriously.
We'll have more on this after the break. Stay with us.
We have to start by the middle of March vaccinating 300,000 people a day just to hit 30 million people.
Welcome back to theZoomer. We know seniors are at risk for the worst cases of COVID and the worst symptoms, and they make up the vast majority of hospitalizations and deaths. Once long-term care patients get their vaccines, seniors in the community are next in line, but there's still a lot of waiting, and that's a point of consternation for one of our viewers. Have a look.
Hi, I'm Ketty Samuel. I'm age 71 and I live in Thornhill, Ontario. How am I feeling? Actually, very frustrated and very disappointed. I don't feel that there is a clear category for seniors living in the community over age 65. We've been lumped in phase 2, starting with age 80 plus, going down in 5-year increments, along with teachers, paramedics, food and construction workers. If we look at the numbers, we have a 24-fold chance of dying should we contract COVID. We make up, seniors living in the community, ages 60 plus, make up 37% of the COVID deaths. If the goal in Ontario is to prevent deaths and clear up hospital beds, then we need to be a top priority.
Well, here in Ontario, General Rick Hillier, who is in charge of the rollout, won't even guarantee a timeline for starting to inoculate seniors, beginning with those over 80. And that wasn't set to happen until April, but now all bets are off because of the delays and cutbacks in Pfizer and Moderna shipments. Meanwhile, Nova Scotia is starting at the end of February. The Prime Minister keeps insisting that everyone who wants a shot will have it by September, but the UK-based Economist Intelligence disagrees. A recent report predicts that won't happen until mid-22. So how does all of that affect the priorities, which at the beginning of all this, we thought were supposed to be older people? Dr. Bowman?
Right from the beginning, we weren't really targeting older people because we began with the hospitals, and that really didn't work out very well at all in terms of who was receiving the vaccine. And it took us away from the whole long-term care and older persons in the community. But, the question of older people in the community, independent of long-term care, it's a tough one. It's clearly a priority. There's high risk within that. And, I think all priorities have to be reevaluated depending on what we've got before us in terms of vaccine supply. And I think we have to be very flexible with all of this and potentially reconsider it.
So just so that you know, the thinking around the contracts as they are, if you remember, many of them are 20 million doses, right? The reason it's 20 million doses is that they wanted to be able to vaccinate 10 million people, because 10 million people is everybody over 65 and those on the front lines in long-term care. So that was the thinking. Unfortunately, those contracts are structured to be delivered in April. So again, that's the heart of the problem. And I feel badly for the provinces and for people who are dying and sick and so on, because it's all related to the fact that we just don't have supply of vaccine. That's the issue. And it puts everybody in a very difficult position to try and determine who should get that vaccine and who shouldn't.
So I actually do think that by September, end of September, people will be vaccinated 65 and over. I'm equally concerned, though, about the fact of how we will roll out the vaccine, because we will get millions. And that's where we need to focus on what we know best: primary care, pharmacies, home care, nurses. Thousands of nurses go to the homes of homebound people every single day. We never use them. Every year we use them, but now we are not even talking about that. Pharmacies are willing to do that 24/7. So it's not only the big new infrastructures we are setting, we need to use the current infrastructures and current doctors, nurses, pharmacists that are already in the payroll and should be put to work 24/7. So we meet the target. The target, in my view, will not be if we get enough vaccines or not in the next many shipments, but how fast we deliver and to whom we deliver first. And that's also, we need to consider other vulnerable populations, people in shelters, people in correctional facilities, et cetera, et cetera.
Yeah, I wouldn't be overly optimistic about September, and it's shades of gray there. I mean, in order to hit the end of September and vaccinate everybody with 2 doses, we have to start by the middle of March vaccinating 300,000 people a day just to hit 30 million people.
If you do it 24/7, it's faster.
That's
Here
right.
you go.
We're
Here
going
you
to
go.
have to vaccinate 300,000 people every day, 7 days a week, and that's going to be a big challenge, and it'll depend too on the flow of vaccines and how they flow
But
into.
Paul, that calculation is not 24/7. I'm saying 24/7.
Yes, it is. From the middle of March to the end of September, you've got 200 days, and all you do is divide that into 30 million and double it.
Dr. Bowman, what about healthy seniors in the community? Have they been forgotten? And the other question I have is, was putting a general with no medical background in charge, was that a mistake?
Look, I have nothing but respect for General Hillier and the other military people. And this is to some extent a military operation, but it's also an epidemiological operation. And is it really fair to them to have the weight of this on their shoulders? So there's real advantages in terms of deployment, but in terms of the ethical questions and the epidemiological questions, this is kind of really, really unfair stuff. It really started to unravel with the hospitals interpreting it their own way, became very problematic. And then secondly, now that supply, I'm not going to say dried up, but it's so spotty now that the question is so hard to get your teeth into because we don't have the vaccines to figure out who to give them to.
It's interesting because it seems to me that with the problems in supply, it's kind of just given everyone an opportunity to blame each other. So the people in charge of the rollout here who diverted a lot of these doses from long-term care where it was needed are blaming. They say, hey, it's an issue of supply. Give me the vaccines and I'll put them in people's arms. So it's getting quite political, I think.
Well, but if you look at the directives, with all due respect, I want to build in our previous colleague, the directives in Ontario were changed from the national priorities. And even it included, the January ones, it included any other employee in the hospitals. So, when a hospital CEO tells you that's what they told us, that's what the general told us. So why did they modify the directives? It's a question. They were very solid. They were very, both from an epidemiological and an ethical perspective. So this is not only an issue of how many vaccines, but how they're distributed and used.
Colin, do you think that Hillier or General was the wrong person to be in charge of this?
I agree that he's a very respected person, a smart guy. We've all been on his learning curve. So he's had to learn public health. And when that decision was made in December to take several days off, just sort of give people a break, there's no one in healthcare who thought that made any sense at all. That meant that healthcare was advising him at all.
Okay. There's more to come when we come back. Stay tuned.
But there's been a long series of errors, and we're really the only SARS nation that really bungled it.
Welcome back. I'd like to go back to something I mentioned at the top of the show. Canada is now 33rd in the world in terms of vaccine rollout, behind very small countries like Cyprus. So the question is both, how did we get in that position? And more important, what do we learn for it? How can we fix this?
Well, I think that's a great question. And, the unfortunate thing is that, we have to take some accountability through our governments for where we are. Think back to SARS. We went through SARS as a country. It was an epidemic in Canada, in Toronto. We came out of that saying, we're going to learn from this. We're going to make changes. We went through H1N1. The federal government said, yeah, we're going to learn from this. We're going to make changes. We're going to document the learnings. And, they scrapped GFIN. They didn't maintain the emergency stockpile of PPEs, vaccines, pharmaceuticals, and so on. They made multiple mistakes. And, you know, Canadians deserve a lot better than what we got through this pandemic. We should have aspired to being like other countries. We should have aspired to being the best in the world. And we had the learnings and we didn't apply them. And that comment applies to the whole vaccine issue.
Dr. Bowman, I mean, what can we do to fix it? And what's your take on how we got there?
Well, look, at the risk of saying something that's already been said, I was around for SARS. I was quarantined. I was a frontline healthcare worker. And I came out of SARS thinking we've learned so much about so many of these things. And at the beginning of this very pandemic, I was saying things like this. I didn't realize we may have learned them. We didn't actually implement anything. So we really, I'm just repeating what Paul has said, we really have to take some responsibility here. How do we get out of it now? I don't know. I personally, and look, I don't have insight on this, but I keep wondering why AstraZeneca, you know, we can't at least get that one on board and why we've got such delays with that one. But we're now in a very complex situation. But there's been a long series of errors, and we're really the only SARS nation that really bungled it. Other SARS nations, remembering they were Asian, have done far better in COVID than we have.
I'm glad you brought up the AstraZeneca vaccine. I have a couple of questions around that. First of all, I'm a little confused because Germany and France are not giving it to older people, over 65 in Germany and over 60, I think, in France. And so my question is it because they know it doesn't work in older people or because they just don't have the data? Colin?
It could be a bit of both. For some vaccines, older folks just don't mount as strong an immune response. I think we have data from Pfizer saying they do. So that sort of makes it, I think, maybe a first choice for older people. It's hard to say. It's a very, very complicated landscape of different vaccinations and different approvals. And it's going to get more complicated.
Mm-hmm. And apparently there weren't many older people in the trials.
That's often the case. Often what you really want to do for trials is you have healthy adults who are less at risk in some ways to get a sense of what is usual, what is typical. And then you go to more marginalized populations. Then you test pregnant women and children and older folks. So it's sort of a stepwise process, but we really condensed the testing. We didn't spend 5, 6, 10 years testing and doing that slowly in a stepwise way. We did it in a number of months. And the AstraZeneca data is a mess. It's actually a methodological humiliation for everybody involved. Multiple studies, none of them directly comparable, data missing, variables missing, mistakes made. It's actually pretty difficult, and you need a lot of Scotch tape if you want to put that together and understand really what are the strengths and possible risks with that particular one.
So when it was approved so quickly in the UK, is that a political thing, you think, Paul?
I don't think necessarily, but clearly the fact that that's an Oxford University AstraZeneca vaccine, you know, they were anxious to approve it, no doubt. And the data set is unusual. So, but I think they decided, look, we need another vaccine. We're going to approve it. We're going to move forward. And we're going to use it. And the data is going to continue to develop. But, you know, it looks like it does a pretty good job, and it's going to do good enough.
Another question I have around AstraZeneca, Doris, and that is that we just learned that Canada contributed to a fund called COVAX to buy vaccines for developing countries. It was announced with great fanfare last year. And now we learned that Canada is dipping into the fund. The only G7 country is going to be AstraZeneca vaccines. But what do you think of that? The only rich, wealthy country taking from that pool of vaccines intended for poor countries.
So the same as with long-term care and other vulnerable populations, I think about not have countries in the same way. Shame for us. Shame for us that we don't understand. Not only we don't understand the ethics of it, we don't understand the virus and virus mutation. That if we leave other countries that don't have vaccines to just continue to go the way they do, that will catch up with us one way or another, not only with them. So even from a selfish perspective, it's not smart.
Carrie Bowman, the ethics or the practicalities of dipping into those vaccines?
Yeah. You know, Libby, what I think it really comes down to is if we reach the point, because we are dipping into them, where, you know, in the month, not now, but in the months ahead of 2021, if we are using those vaccines on low-risk Canadians, when in fact high-risk people in the developing countries are not receiving them, we've got a real ethical problem on our hands. And, you know, looking at the international media today, this issue of Canada dipping into COVAX is getting more attention internationally, it seems, than nationally. It makes us look bad. And I think I was very shocked to see that we're doing it. The public doesn't want to hear it right now. There's so much anxiety in this country about vaccines that when we start talking about giving them to other countries, you get a lot of rolling of the eyes. But, you know, this is a moving game, and we will see.
Okay, we'll have more on this when we come back.
You're not going to mandate vaccines for people when there are no vaccines to take.
Welcome back. The federal government is mandating COVID testing for returning travelers, and rapid tests are also being deployed at workplaces, long-term care homes, and schools. Is mandatory vaccination far off? We've been hearing speculation that we may need proof of vaccination to travel, attend concerts, or even go to work. We're joined now by Michael Bryant of the Canadian Civil Liberties Association to talk about the legal and privacy issues surrounding COVID-19. Hi, Michael. So I think last week saw an item from the United States, and they have a ruling, an ancient legal ruling that said, yes, workplaces can mandate vaccination.
So I wish we were talking about this as something other than a hypothetical issue. As long as we have demand outstripping supply, this is just a hypothetical issue. We don't have the supply to make this possible, right? You're not going to mandate vaccines for people when there are no vaccines to take. You know, the problem with dealing with the hypothetical and saying, yes, of course we can mandate vaccines, is I think you feed into some of the fears that drive anti-vax thinking. And in the case of employer mandated vaccines, we'll just have to see whether, you know, if we ever get to the point, and it won't be until later in the year, where this would be possible. Why? Because we don't have enough vaccines to mandate even one.
I'd like to turn to Doris now, and frankly, I find it shocking that even now, workers, nurses in high-risk healthcare facilities, they are not required to take vaccines. You can't force them to. My understanding from the rollout that happened in the hospital was that there are quite a few long-term care workers that refused it. So what's your view of that?
Yeah, so a couple of things. First of all, we need to understand, especially in relationship to long-term care, the racialized community of workers that are poorly paid, poorly treated, PSWs in particular, that come from a history of very heavy, similar to indigenous communities, a heavy history of trials done to them. So the approach is not mandate the vaccine, but know how to speak with them and know how to understand and listen and respond. Now, employers have a right, as with the flu, to mandate masks forever, et cetera, right? But I don't think it will be conducive to mandate vaccines versus have champions of vaccines. It's very important to understand that right now we don't have enough vaccines to have that conversation and fight. Let's dedicate to bringing people on board and say, I'm ready.
Carrie Bowman, what's the ethics of that? Should people in healthcare have to take vaccines? And I think we're all looking to the reopening of the economy. I fully expect that there are probably countries I want to visit that won't let me in unless I can show proof of vaccination.
Travel's a given, Libby, as you've indicated. I say it's a given. I don't have proof of that, but I believe, and many people do, it's a given. But look, mandatory vaccination within our country, in a mature democratic society, I think would be very, very destructive. We also, first of all, we don't have the vaccines, but we have to see what the uptake is. We have to see, are we reaching herd immunity? I mean, in the worst case scenario, if we absolutely had no capacity to get anywhere near herd immunity, we could potentially revisit it, but I think it would be very destructive and it would feed into anti-vax. And look, you mentioned, people in long-term care. I know people working in critical care, ICUs that won't take the vaccine. So, this is the reality of the era we live in. There's people out there that say, I'm not doing it.
Well, vaccine hesitancy isn't one big, or vaccine resistance isn't one big thing. There's 2% of the population roughly is hardcore anti-vax. You're not going to change their minds. Many people, strong majority, are pro-vaccination. And then there are those who are vaccine hesitant. They're not sure they trust it. It includes, I think, as Doris said, a lot of racialized groups who do not have a trusting relationship with our healthcare, with government. And so the key there is education. And the key to that actually is relationships with primary doctors. We actually don't train our physicians to have meaningful conversations with patients about that. The other thing I wanted to point out was research I did a few years ago around vaccine hesitancy in hospital workers in a hospital in the US was around the flu vaccination. Less than 10% got it, even though it was a cancer hospital with immune compromised patients. Then they didn't mandate it. They said, you've got a choice. Unions go home. You've got a choice. It's fine. No one needs to get upset about this. Get the shot, or, and now this sounds kind of quaint, wear a mask all day, every day. Vaccination rates went 95%. And then we did an attitude survey and we discovered that all the vitriol had disappeared. The people who were claiming the vaccine was dangerous and not safe and unfair were now saying, it's my professional duty to do it. So attitudes moved with behavior, and it's all around not forcing, but creating an influence, creating the conditions where it seems attractive, coupled with education. So we can get there.
Michael, I see you nodding your head, but my question is, do you expect to be suing employers or other parties that tell their employees, you want to keep working here, you've got to get vaccinated?
Well, I think actually we may find ourselves intervening in those cases. I would expect it would be unions that would probably be more likely to be bringing those actions. I want to be clear that the law, it just boils down to what's in the contract. And if it's not in the contract, it's what is reasonable. And it will depend on what the function is. But the law's approach is more controversial probably around the area of privacy and the disclosure of health information and these the possibility of so-called immunity passports. That's where it might get tricky with employers and with legislation. But we always start when it comes to personal health information with the presumption that it is private and it can only be released with people's consent. That's going to be, I think, a more pernicious issue facing us in 2021 and 2022 than any vaccine mandate.
Thank you so much, Michael, for joining us for this segment. When we come back, some lingering questions about COVID-19 and its impact on our daily lives. Stick around.
Every province has its own different information system. It's very difficult to achieve a sense of what's going on.
Welcome back. Even with delays and massive missteps of the past 2 months, most Canadians should have access to the COVID-19 vaccine by next year. Will that mean it won't be a problem anymore? With all the new variants, though, we're seeing, is there the danger of a third wave?
All viruses mutate. The one thing we have going for us, and this I can't emphasize enough, is an enormously helpful thing. This coronavirus is a slow mutator. It's got a gene that slows down mutation. That's good. That means we can get out in front of it. Measles virus mutates, but the same vaccine's been working for a long time. Flu virus mutates very rapidly, and it hasn't. So it's partly an open question about what natural selection does. I suspect when we think about 2 doses, I think we should be thinking more like 3 or maybe 4 or maybe more than that over the next year or 2 as we play whack-a-mole. But the slow mutating rate, unless we get really unlucky, makes me feel like we win and COVID becomes something that becomes under control globally.
So does that mean that all these lovely announcements about getting our own production capacity are not going to come too little too late, Paul Lucas?
Well, I think it's a good strategy. I mean, we made the mistake of watching the industry deteriorate over the years, and I think we're paying the price now, obviously, and so rebuilding that capability and building it beyond what we had before is really the right strategy. And unfortunately, again, the pharmaceutical vaccine sector in Canada is not a strategic industry for this country today. And you've got to start rebuilding, you've got to start attracting investment, you've got to start building capacity, and it's doable. But again, it takes good planning, it takes the right incentives, it takes the right policy agenda, and we're not there.
Dr. Bowman.
Yeah, the variants are here. And, as far as I know, and I'm not an expert on virus, it's kind of all variant now. The question is whether the variants are a threat to us or not. And, that comes down to surveillance. And, I think it's great that our country is finally beginning to take, and I speak of disease surveillance, much more seriously. But surveillance is going to have to be, if we're going to protect our people, surveillance has to be a very high priority in terms of, viral threats. Also, my question with the variants is how many variants don't we know about? I mean, variants that are somehow a threat, because it's all variant as far as I can understand. Yeah.
Clearly, this isn't going to be the last pandemic, and it could be a very different virus next time. So having that capability to produce vaccines and be flexible, is really critical to our country.
Yes, agreed.
Doris, is our system ready for a third wave? Are people even thinking about that?
Well, I think we better think about that so we can delay it, not prevent it, but delay it. And it's not related to the variants also only, and it's not related to the vaccine only, it's related to public health measures and how much governments will want to do or not related to public health measures. And that has been, if we are talking failure of vaccine, let's talk failure in implementing and ensuring that public health measures happen in time and in sufficient strength so that we suffocate the virus and the variants. We have gone from 30 variants to, I believe right now, if you read the science, it's about 150. So the variants will continue to happen, bigger or smaller that people don't talk. The better public health measures, stronger and in time, and the faster the vaccination, we will get over with wave 3 and hopefully wave 4.
Colin, I hear some people say the problem is that public health was not more involved. I hear other people say, well, there are so many little public health units, and if you can believe it, their fax machines don't talk to each other, and that is the problem. I know, for instance, even with a flu clinic, right? This is anecdotal. People who get their flu shots in a public health clinic, on average, had to wait almost a month longer than those of us who just went to a pharmacy. So do we need more public health, less public health, or just updated public health?
That's one of the hardest questions I've had in quite some time.
Oh, good.
Part is, what is expertise in the age of COVID or a giant pandemic? It's not even clear who should be at the table, and when they are, they argue with each other a lot. I think it's actually an interdisciplinary problem. So we assemble teams of experts, but we don't have any expert teams. And I think it's very difficult to deal with these gigantic problems. Every time you solve something or create an intervention, you're also creating other kinds of problems you need to contend with. It's just enormously complicated. But COVID is also an information problem. There's no question it's an information problem. Moderna vaccines being tracked by paper. Every province has its own different information system. It's very difficult to achieve a sense of what's going on in order to inform decision making. So regardless of who's at the table, if you're not actually doing the surveillance and measuring it and getting the data there and it's reliable, you're still blind. And it doesn't matter what you know. If the lights are out in the room, you still don't know. You still don't know what, where to go and what to find. That's the problem we have. So it's complicated.
Okay. When we come back, final thoughts from our panelists. Don't go away. Welcome back to theZoomer. It's time for final thoughts. We'll start with Dr. Bowman.
Well, final thoughts would be, I'm considering the ethics of what lies ahead. And I think when the vaccines start rolling in again, we need to get back on track. I think we've learned some lessons as to where we want to target, the most vulnerable people. I think we have to consider elderly people in the community. And that's a major consideration. I would just simply add, we need surveillance because of the risk of the variants. Doris.
I would ask that we remember that we are part of the broader world. What happens somewhere else, affects us here. That we focus on public health measures until we get lots of vaccines, and then we go 24/7 with primary care, home care, and public health delivering 24/7, and we will get it done.
Paul Lucas.
The reality is that we're going to receive 6 million doses of vaccine by late March. And after that, we should have a significant vaccine coming into the country. So if you're a senior and you're 65 and older, your anticipation should be that you're going to get vaccinated fully, and that means 2 doses in most cases, by April, May, June, probably. So, other than that, just relax.
Colin.
Public health needs public investment. It needs resources. And I'm just going to go ahead and say it flatly. We need to demand higher taxes to pay for public health. It's not going to come on by itself. It's not free. We've been diminishing public health, and I'm going to throw long-term care in there as well. We've been diminishing it for 3 decades. We need to reverse that. We need to do it radically. The things that I have seen in Ontario over the last year are a humiliation I will never forget. Migrant farm workers, long-term care homes, homeless shelters. It's appalling. We need to pay for it. We need to pony up.
Okay. The bottom line is that we won't be getting back to anything resembling normal until those vaccines find their way into our arms. Thank you to my panelists for being here and to our audience at home for watching. For now, it's time to zoom out.